welcome to the Stronger After Stroke podcast. I'm your host, Rosa Hart, the stroke nurse navigator for Norton Healthcare in Louisville, Kentucky. And joining me today is Dr. Brian Plato. He is a migraine specialist. Thank you for being here with us today.
Thank you for having me, Rosa.
Would you tell us some more about your specialty?
Sure. So my job here with the Norton Neuroscience Institute is I'm the medical director for headache medicine. And so as a specialty, headache medicine is involved in treating people who have headache and facial pain conditions. And the most prevalent thing that we see, which we'll be talking about a lot today, is migraine.
So you have board certification in neurology and headache medicine. And
Correct.
There are not a lot of actual headache specialists in the world, from what I understand.
So that is correct. So yes, I am board certified in neurology, and then I have additional training and board certification in headache medicine. This is a growing number of physicians, but still compared to, taking the population of people with migraine, which in the United States is almost 40 million people, to have 600-700 board certified specialists is nowhere near enough to take care of that population of people.
Yeah, and I just really wanted to emphasize that because there's a lack of access to care. There's a lack of access to getting answers from people who really know the answers to these questions. So I just want people to appreciate the value of your time in sharing this with them.
Absolutely, yeah.
How does a headache qualify as a migraine to start with?
So the first thing that I think is important to say and to emphasize to your audience is that migraine is not a headache, okay? Headache is one of the symptoms of migraine.
Oh.
So it is important to understand that migraine is a neurological condition that has a variety of symptoms that may or may not include headache. Okay, so you do not have to have headache to actually have migraine.
Wow. I have heard you talk multiple times, and that still sounds new to me. So thank you for clarifying.
So the symptoms, the classic symptoms that we think of migraine. So headache is probably its most famous or well-known symptom.
Yeah.
But there are headache symptoms and then the non-headache symptoms of migraine. So to diagnose migraine, we're talking about an individual having repeated attacks that last anywhere between 4 and 72 hours that include headache that has two of these four features. So one-sided, throbbing or pulsatile, moderate or severe, and then worsened by or causes them to avoid physical activity. So those are the headache features. So someone coming in with headache, we're talking about those features to diagnose migraine. And then the non-headache features would be light and sound sensitivity, nausea, and or vomiting. So then, because I mentioned it, I'll say a little bit more.
Mm-hmm.
So about 20% of people who have migraine will experience aura, which refers to the transient neurological symptoms that either precede or accompany a migraine attack. Almost all people who have aura will experience visual symptoms, but other symptoms of aura can include things like numbness, language difficulties, sometimes weakness, and rarely, significant states of confusion or other symptoms. Okay, and so it's possible that an individual can have that migraine aura, but then never really progress on to develop the headache phase of the migraine attack, which can get very difficult in diagnosing, which I think we're going to talk about later, is sort of the stroke mimic of a migraine attack.
Exactly. And that's why we felt like it was so important to have this conversation, because someone who has experienced a stroke, and if they have a history of migraines, they want to know, is it connected? And how do I know if I'm having a stroke or if I'm just experiencing migraine symptoms? And just to clarify, you listed a plethora of symptoms there.
Yeah.
Would dizziness or balance changes ever be part of a migraine or migraine aura?
Correct. So many people who have migraine will experience a sense of dizziness, which many times they have difficulty describing the sense of dizziness. It's not so much a rotational, what you think of as vertigo. Many times patients might describe it more akin to like the sensation of being on a boat, just sort of this like having trouble, getting my bearings, maybe walking straight, just really feeling off balanced. So absolutely dizziness can be one of those symptoms as well.
Okay. And I want to define a term that we've used already is transient. Transient means it goes away.
Right.
So it's not permanent.
So yes. So by definition, these transient or temporary symptoms of migraine aura last between 5 and 60 minutes. Now they can happen in succession. Perhaps an individual begins with visual disturbances. Let's say starts with a few minutes where they're having difficulty with seeing in one side of their field of vision, or something growing in terms of a loss of vision in part of their visual field. And then next they sort of they get this sensation of numbness kind of creeping up their arm.
On one side.
Typically on one side. Then, they get this sense of difficulty with language. And so you might see these symptoms happening in succession. And many times for me, let's say I'm evaluating someone in the emergency department or in the hospital, or even someone coming in for follow-up, and they say, I was diagnosed with a TIA. Okay, so a transient ischemic attack. And we're talking about, what that diagnosis, really is, because there's huge differences in terms of the management of someone who has had migraine aura versus someone who's had a TIA. And one of the big clues for me is many times is this progression of, it started with this symptom, then it was this symptom, and then it was this symptom. That typically tends to be the case for someone experiencing migraine, whereas with TIA, it sort of is, all of these symptoms were simultaneously occurring.
Yeah, and that makes total sense, because with a stroke, an ischemic stroke, when a clot or something is obstructing the blood flow to a certain part of the brain, those symptoms come on suddenly, all at once. And so knowing to look for a progression, and that does relieve a lot of fear that people might be feeling, like I'm having these stroke-like symptoms. I'm having numbness in one of my arms, or my vision's being affected, and I feel dizzy. And that's very helpful. And so thank you for defining that.
Mm-hmm.
Are there any other ways that we can tell the difference between stroke-like symptoms and a migraine aura, or is that the key thing?
Well, so a big one is the history, or many times we might see a patient and say, look, the future is going to help us better understand really what this condition is. Let's say someone has had their first attack. Sometimes it can be very difficult to distinguish a migraine attack versus a TIA,
Especially if it's the first time.
if it's the first time. Many times, right, they'll end up in the emergency department and they get lots of scans and MRI scans and things like that. And that helps us differentiate. But as you know, by definition, a TIA does not show any abnormalities on MRI. And so, then it's that history. Now, the other thing is, and I think that many times when I say this following thing to patients, they are a little bit surprised, is I tell patients, let's say someone comes in and they've been having these symptoms for several years and they've had 10 attacks. And each of those 10 attacks was exactly the same. It started with this, then it was this, then it was this. I say to them, the fact that you have had this exact same set of symptoms so many times is more reassuring to me. And they sort of look at me and they're like, why would you say having this more often is better or more reassuring? And it's because then what you want to understand is what's happening in the brain, okay? So during a migraine aura, what's happening in the brain is this is an electrical wave of energy that typically is starting in the back of the brain and then slowly migrating forward. And so that explains why when it's affecting this part of the brain, you're experiencing this symptoms, and then it moves a little bit more forward and it's these set of symptoms. And migraine aura is generally very stereotyped. It sort of starts in this part of the brain, and each time is the same symptoms over and over and over. That's what I mean by stereotyped, is each attack is the same.
Not that people assume things about it, but the same thing happens over and over again.
Correct.
Okay.
Whereas what happens during a TIA, as you said, is it's a blood vessel that is temporarily being blocked by a clot or something else that then dissolves away and then restores blood flow. And so if you think about the anatomy of the brain, the vasculature anatomy of the brain, is I tell patients it's like a tree that then branches off into a million tiny pieces. And so whatever little branch is being blocked, whatever part of the brain that branch serves and whatever function that part of the brain serves for us, that's the function we're going to lose. And so if you think about it, how statistically likely is it that 10 times, a little clot from our heart shoots up into the main tree branch or trunk and then goes to the exact same little branch for about the same amount of time and then dissolves away, right? That is so statistically improbable. I oftentimes compare that Price is Right game where you drop, I think it's called like Plinko or something, where you drop the thing in, how likely is it that 10 times you drop it in the same place and it ends up at the same end result? That's not likely. So that's why when I tell patients, the fact that you've had this, a dozen times is more reassuring to me.
And when you're talking about the electrical activity wave happening in their head, this is something I learned in preparation for our interview, is you can actually see that on a brain scan, the EEG.
Well, so yes, in a way. So
enough to prove it.
Well, so the original term here is something called cortical spreading depression. So what cortical spreading depression is it's this wave of electrical energy over the brain. And in the 1940s, when we didn't have fancy things like MRI scans and CT perfusion and all of that, they used EEG. And what they demonstrated is that there was this slowly progressing wave of reduced electrical activity of the brain that was corresponding to what part of the brain this cortical spreading depression was happening in. And so, yes, sometimes you might see some EEG abnormalities on an individual who's experiencing a migraine attack, but that is not what we use to diagnose it. The diagnosis is a clinical history, and so it really is not necessary to be doing tests like EEGs on these patients because what really matters is the story that the patient is telling us.
For diagnosis.
For diagnosis, yeah.
I just wanted to say that was reassuring to me that you didn't just make that up.
Oh.
There is evidence.
I hope that I'm not making up things here today. But the fact checker will come back later, yeah.
But that's something that they can look into to see you didn't just pull that out of thin air. It's been documented since the 40s.
Right. So, and I tell patients that, migraine is just a fascinating brain condition. I think that, so many people just have this misunderstanding that, migraine is just this bad headache and, someone's, laying in the dark room or something like that. But, from an electrical standpoint, from a chemical standpoint, all of the different parts of our brains that are being activated during migraine, which corresponds to this multitude of symptoms, it's just so fascinating. We're just starting to scratch the surface and understand what is happening to our brains during migraine attacks. And as we better understand this, we can come up with better therapies.
So that has been very enlightening. I want to pivot a little bit to a serious note of, I think you get a lot of questions about, do strokes cause migraines or do migraines cause strokes? Is there a relationship there?
So there absolutely is a relationship. And so we'll take those one at a time. So does migraine cause stroke? So in very rare instances, an individual can experience a migraine attack that begins like their typical migraine attack and ends in something that is called a migrainous infarction, which is actually where that part of the brain does actually, those brain cells actually do die. That is extremely rare. However, what is a more important, or a very important topic to discuss, is the link between migraine as a risk factor for stroke. Okay,
Okay.
so migraine with aura. So those individuals who have migraine that have those transient neurological symptoms that accompany their migraine attacks is an independent risk factor for stroke. Now, the population that is specifically being studied here when we talk about this is a younger population. So we're largely talking about individuals under the age of 45. These tend to be the individuals that don't have a lot of other significant risk factors for stroke. And so when we get into it is that the risk of stroke in an individual who has migraine with aura might be 2 times as much as the general population. And so you can think of this as what you would call non-modifiable risk factor, right? You can't change that. Somewhere buried in your DNA is the fact that you have migraine with aura. And so the question is it something particular about migraine with aura that leads to this increased risk of stroke, or is there something common that these individuals have as, let's say, some genetic defect that makes them more likely to have migraine with aura and also increase their risk of stroke? Why I bring this up in conversation with my patients is, let's say I'm seeing a 17-year-old that has migraine with aura. Probably the last thing on the mind of a 17-year-old is that I have an increased risk of stroke because I have this diagnosis of migraine with aura. And so, at that point, I'm talking to them about things like, hey, compared to your other 17-year-old friends, it's very important that, you are not smoking. It's very important that, you're leading a active lifestyle. It's important that, all these other things that we think of as healthy things for reducing our risk of stroke that, again, aren't on the forefront of the minds of these younger individuals, the same way as if you had a very strong family history of cardiovascular disease. Let's say everyone in your family died, from a heart attack at age 45. You might then be more aware of, hey, this is just a part of who I am, so I need to take these steps to reduce this risk. Taking this conversation a little bit further and making it a bit more less clear is in females, particularly younger females. Oftentimes, an important part of their health is the use of contraceptives, particularly estrogen-based contraceptives. So this is also, a difficult topic to look at in terms of studying, because to say, taking an estrogen-based birth control pill doesn't necessarily mean the same thing across the board. There may be higher doses of estrogen, there may be lower doses of estrogen. So if you look back in the 1970s, it seemed rather clear that the estrogen-based birth control pills of the 1970s did carry a higher risk of cardiovascular and cerebrovascular events. Now, estrogen-based birth control pills of the 70s contained significantly higher doses of estrogen than what are being used in modern birth control pills. And so now with modern birth control pills that contain, 10, 20, or, sometimes higher doses of estrogen, the risk of vascular events is not exactly clear, depending upon which study you look at. And so the question is are there additive risks? And this is difficult because, a female may choose for family planning purposes, or maybe she has endometriosis or some other condition that requires the use of estrogen. And so it all is about having a conversation with your doctor and understanding what really are these risks and, what other things are modifiable. So for example, if you have migraine with aura, you're taking estrogen-based birth control, and you smoke cigarettes, the risk of stroke may go up as much as 34 times compared to someone else in your age group. And so, in that individual, you certainly, would risk stratify them to a much higher level versus, let's say, a very healthy 25-year-old female who exercises regularly, doesn't smoke, doesn't have a family history of vascular disease. That might be a different risk stratification. And so these are just important things, I think, for people listening to know that, these are just conversations, to bring up with, whoever it is that's treating you for this.
And to know that there are different levels of estrogen, and then there are other hormonal birth control options that don't even contain any estrogen.
Correct.
You can definitely explore with your doctor if you want to take a pill versus have something implanted, then those are options you can discuss with your doctor. You don't have to just take the first thing that they're like, okay, I'll just prescribe you this thing. It's got great evidence. Well, they may not know that you're extra concerned about stroke or migraine.
Or it might not even be that, if you're going to see your gynecologist, you might not even be on your mind to be talking about
your headaches,
the fact that I have migraine. So it just is bringing into the conversation how a diagnosis of migraine is an important diagnosis to make and to let all of your healthcare professionals be aware of.
Yeah, even if it seems unrelated.
Correct. Now, the flip side, the other half of this question that you asked about is, does stroke cause migraine? And so while it is not by any means that everyone who has a stroke is going to go on and develop migraine-like headache, it actually is fairly common in our practice that we'll see someone who, maybe they had a stroke and then they start having headache as a subsequent, byproduct of having a stroke, especially those that have hemorrhagic strokes. So people who have a history of, subarachnoid hemorrhage, many times those individuals end up long-term having problems with migraine. This history of having a stroke does complicate our treatment of those individuals that have migraine, as many of the medications that we use in treating migraine may be contraindicated in an individual that has a history of cerebrovascular disease. And so we just need to take that into consideration when we treat these people.
By that, you mean if a history of cardiovascular disease like high blood pressure?
Cerebrovascular disease. So for example, a class of drugs referred to as the triptans.
Yeah.
So these are medicines that are used on an as-needed basis for when an individual has a migraine attack.
Is that what they call rescue medicines?
Right. So this would be an example of a rescue medicine, and this is a class of them. So the famous one is Imitrex or sumatriptan, but there's 7 drugs in this family. These drugs are contraindicated for an individual who has a history of cardiovascular disease or cerebrovascular disease.
Okay.
And so
the same for ischemic strokes versus hemorrhagic strokes?
So it gets a little bit complicated in that discussion, as it's more labeled for cerebrovascular disease. The concern is that these drugs can cause some vasoconstriction of arteries.
Okay.
And so in individuals who have predisposition to arterial vascular disease, that's where that warning really comes from.
Okay. So does smoking increase the likelihood of migraine? We know it increases the likelihood of stroke.
So smoking, well, I don't think you're ever going to find a doctor tell you that smoking is a good thing for you.
Right.
And so any reason I have to encourage a patient to discontinue smoking. In terms of smoking as a risk factor for migraine itself, I think that it might have a slight
as a trigger, maybe?
Right, the scent of smoke, triggering migraine. But overall, I'm not aware that, cigarette smokers carry a significantly increased risk of having migraine. But as you mentioned, that smoke around them might be a big trigger for having migraine attacks, and
which
certainly
might motivate them to avoid it anyway.
Correct. But certainly, smoking, again, combined with migraine with aura, does increase the risk of stroke.
Okay. So, what can someone do to live their best life if they have migraines and if they've had stroke?
So the first thing I'm going to say here, Rosa, is so when we talk about migraine, it's important for us to recognize migraine as a condition. And so what we're going to say is we're going to say an individual who has migraine, not an individual who has migraines. We might refer to an individual migraine attack, but we're talking about the condition of migraine itself.
Okay.
So that's just an important distinction when we're talking about this condition. So for an individual who has migraine, in terms of lifestyle, so I will oftentimes, when I'm seeing someone who has migraine, compare it to diabetes. And I tell them, look, you have an incurable condition, but this condition can be managed through lifestyle and medications. And so from a lifestyle perspective, things that can be helpful in managing migraine. So we oftentimes are talking to our patients about getting good sleep. So unfortunately for migraine, many people who oversleep, so it's that Saturday morning, nothing on my agenda, so, I'm going to sleep in. Actually, many times that oversleeping can trigger migraine attack just as much as undersleeping. So we really want to have consistent sleep schedules, about 6 to 8 hours of sleep at night. Skipping meals is a big one. So, a lot of people get busy during the day and they might skip lunch or something like that. And it's that skipping of meal that might trigger a migraine attack. And so we want to make sure that we're consistently eating throughout the course of the day. And I really try to encourage the eating of good, real food. So patients will often say to me, should I go on this diet or that diet? And what I really want to encourage them to do is don't go on some fad diet. Instead, just eat real food, try and minimize all the preservatives and things like that, and eat consistently throughout the day. Next, stay well hydrated. So shoot for a target of about 2 liters of water a day. I know that means you're going to be rushing off and you're going to know where every bathroom in your workplace is, but staying well hydrated can be important for managing migraine. Exercising regularly. So it looks like the target number is about 150 minutes a week of cardiovascular exercise. So whether that's spread out throughout the week of 5 days a week doing half an hour, or just sort of the weekend warrior, going at it, that target number seems to be important.
Are you telling me we can binge exercise and it still counts?
So you can on Saturday morning get up and ride your bike for 2.5 hours, but really shooting for that target goal of 150 minutes a week. Then we might get into conversations about some other areas. So for example, something that you hear a lot about is something that gets referred to as mindfulness. So I am by no means an expert, but I talk about this on a daily basis. So particularly mindfulness-based meditation is the practice of trying to recenter how external stressors and things that happen in our daily life, how we are then internalizing those. So, rather than something coming in and sort of us automatically reacting to this in a negative way where it gets our adrenaline surging, is instead, a stimulus coming in. So maybe that's someone cutting you off in front of traffic. Rather than immediately responding, is, sort of taking a moment, adjusting how, this is affecting us, and then making our reaction. And so there is great emerging evidence of just how powerful of a tool mindfulness-based meditation can be in managing migraine in terms of reducing migraine attacks and reducing how much they affect us.
So does that mean everybody needs to start doing meditation, or is this more of a throughout your day, pace yourself moment by moment practice?
So I think it's a little bit of both. So, in meditation, one is going to take time, whether that's just 1 minute or whether that's half an hour, of really trying to work on clearing those thoughts. And I use this example with my patients is, if you're a basketball player You're not going to just sort of wing it and step up to the free throw line, in the game and say, I can do this. Instead, what you're going to do is outside of the game is you're going to practice those free throws, right? And the reason you're practicing them is so that then when there's 1 second left in the game and you get fouled and every fan is watching you, you can say, I've done this a million times. This is no problem for me. If we aren't practicing this, if we're not taking this time to practice mindfulness through meditative sessions, when your boss walks in and says, "Hey, Rosa, that assignment I said could be due next week, it's actually due tomorrow," rather than immediately saying those things under your breath that you probably want to say, it's what, I've been practicing this because I take this time, I practice my mindfulness-based meditation, I can pause this reaction, I'm feeling this reaction in my body, and I can just sort of pause, take a moment to reflect, and then have my reaction and have it be less of a stress-provoking reaction.
More of a measured response.
Right.
Yeah, I like that. So how can people learn more about migraine from you?
So, well, I would like to say that, we have, all day, every day to see every patient. As I mentioned earlier,
I think you have a waiting list, don't you?
Unfortunately, all seriousness is, that I said earlier, this is a serious condition. There's a lot of people who have it, and there just are not enough, people out there. Now, fortunately, here at NNI, we actually are growing our team quite a bit. And we do have several doctors who are board certified in headache medicine, but recognizing that we aren't able to see every patient around the country, we have come up with these online videos that we call Headache School, and I'm sure Rosa can make a link available of how to access these that go through our classes of what is migraine, what are the medications used to treat migraine. Dr. Davis from our team, I think, does a session on some of these non-medicine options in managing migraine.
Yeah, our podcast listeners probably remember him from another episode of the Stronger After Stroke podcast.
Yeah, he's great. He's a great part of our team. So all of those videos are available to watch online.
Yes, and we will include a link in the show notes so that you can sign up to see those videos. They are on demand all the time. They're not just up on YouTube, but it's a great way to get some more in-depth information from the other experts on the team as well, and stay in touch with Norton Neuroscience Institute for our other virtual programs that we offer as well. So thank you so much for being with us today. I feel like this was really enlightening, even though I've talked with you and listened to you before, I still ended up learning things. So
great. Happy to help.
you.
Thanks for having me, Rosa.
All right. And we'll see you in the next episode of Stronger After Stroke.